My name is Irfan Saeed, and I'm one of the transplant surgeons working at Agusta University. I want to thank Shalamar Surgical Symposium team and especially Dr. Talat Wasim for giving me the opportunity to talk about liver transplantation today. I have no financial disclosures. Objectives for today's talk are history of liver transplantation, indications for liver transplant, SRTR data, complications related to surgery, and a video regarding liver transplant. So the history of liver transplantation started in 1901 when Karl Landsteiner discovered blood groups. This was further enhanced by vascular anastomosis technique development by Alexis Carrel, and both these gentlemen got their Nobel Prizes for their respective work in early 1900s. In 1967, Dr. Starzl performed first liver transplant at University of Colorado. He was the pioneer in the art and knowledge of liver transplant and had also several other contributions to the field of transplantation. I had a distinct honor of being trained by one of his fellows, an exceptional surgeon, Dr. Joran Klintbaum. In 1984, first diseased split liver transplant was performed in France by Henry Bismuth. And in 1989, first successful living-related liver transplant was performed by Dr. Broche at the University of Chicago. This is one of the iconic pictures of Dr. Starzl working at the University of Pittsburgh, which was the mecca of transplantation for a long period of time. Indications for liver transplant. The indications for liver transplant is a long list, but the most common reasons are alcoholic and NASH leading to cirrhosis requiring a liver transplant. The number of hepatitis C patients requiring liver transplant is going down, and HCC. Let's talk about SRTR data. SRTR stands for Scientific Registry of Transplant Recipients and is the comprehensive data collection registry for transplant patients. It releases its reports on almost a yearly basis and highlights the trends in transplant rates and patient demographics. This first slide shows the distribution of adults waiting for a liver transplant by diagnosis, and as you can see that the number of patients who had hepatitis C cirrhosis requiring or needing a liver transplant is going down because of the newer medications for treatment of hepatitis C available in the United States and all across the world. Alcohol and NASH are still one of the top reasons in the United States for liver transplantation. This slide shows the number of transplants which are being performed in the United States, deceased and living donor, and you can see that the number of deceased donor liver transplants is going up for the last several years. The number of living donors have not changed a lot due to donor availability and strict regulation for living donation. This slide echoes the previous slide regarding diagnosis. The number of total liver transplants performed by diagnosis show the same trend as waitlist, and you can see that the number of patients with hepatitis C requiring a liver transplant are going down. Let's talk about the graft failure among diseased donor liver transplant recipients. And as you can see that in early 2000, the 6-month graft failure rate was almost 16 to 17%. which has now decreased to less than 10%. And similar trends are seen in 1, 3, 5, and 10-year outcomes. This is probably due to better immunosuppression, which is prograf, better ICU and intraoperative care. Graft failure among adult living donor liver transplant recipients, and you can see the same trends at 6 month, 1, 3, 5, and 10 years. Now we will focus on liver transplantation techniques, and we're going to talk about two basic techniques for cadaver liver transplant. The fundamental principle of any liver transplant procedure is to establish inflow, outflow, and a track for bile flow from donor liver to recipient. In case of liver, there are two inflows, portal vein and hepatic artery. Outflow is IVC, and bile duct anastomosis and reconstruction between donor and recipient. The first technique we talk about is caval interposition technique. In this case, the recipient hepatectomy is performed with retrohepatic IVC. The number of anastomoses which are performed in this type of procedure are suprahepatic IVC to recipient IVC, infrahepatic IVC to recipient IVC, portal vein to portal vein anastomosis, hepatic artery to common hepatic artery or confluence of common hepatic artery to GDA artery, and a bile duct to bile duct anastomosis. In case of piggyback technique, the recipient hepatectomy is performed without IVC resection, and the anastomosis performed in this procedure are a suprahepatic IVC to hepatic veins, no infrahepatic IVC anastomosis, a portal vein to portal vein anastomosis, a similar hepatic artery to common hepatic artery or GDA confluence anastomosis, and a bile duct to bile duct anastomosis. So in comparison between two procedures, there's one less anastomosis to be performed in piggyback technique, and second, the chances of post-operative bleeding are less as there's no dissection of IVC performed in the recipient. Let's talk about some complications which are related to this procedure. The complications can be divided into two main categories, early and late. Early complications happen in first several days to a couple months, and late complications can happen after 3 months in these patients. Bleeding is one of the most common reasons for these patients to go back to the operating room. Other main complications which will require a retransplant are primary non-function, hepatic artery thrombosis or portal vein thrombosis. Bile duct leak can also happen, along with the other listed complications immediately after surgery or sometime later.